So a very good morning to everyone. I, Dr. Poonam Joshi, welcome you all once again to our ac- academic classes. As today's speaker is Dr. Krishnakumar Thankkapan sir. Sir is professor and head of the department in Department of Head Neck Surgery at Amrita Institute of Medical Sciences at Annakulam, Kerala. So he will be speaking on dysphagia in head neck cancers, the diagnosis and the management. Sir, you have joined. Please wait for 2 minutes. Sir is joining.
Hello.
Yes, we can hear you, sir. Sir.
Good morning, everybody. I'm sorry for the delay. There was some confusion in getting the link and starting. So let me go straight away to the presentation. Thank you very much, Poonam and other organizers for this wonderful online meeting. Yeah, I hope you can see my screen.
Yes, sir, we can see.
Yeah. So the topic today is dysphagia management in head and neck cancers. For those of you who don't know me, I'm Dr. Krishnakumar from Kochi. So head and neck cancer can involve any of these sites. As you see in this picture, it can be from paranasal sinuses to the larynx, hypopharynx, and even up to the pleura. So management of head and neck cancers is generally with surgery, radiotherapy, or chemotherapy. And early stages usually is treated with a single modality, meaning that either surgery or radiotherapy. And advanced stages usually require a combined modality treatment. Dysphagia or difficulty in swallowing in head and neck cancers can be pre-treatment, that is because of the tumor itself, or it can be due to post-treatment. And that can again be due to surgical reasons, non-surgical reasons, or combined causes. Surgical dysphagia depends on the extent of the resection, the structures resected, and the nature of reconstruction. Now, coming to non-structural surgical dysphagia, it can be due to the radiation or chemoradiation, which is given as a primary treatment or as an adjuvant treatment. So this can result in non-surgical dysphagia. With that introduction, let's move on to the evaluation of the dysphagia. I'm not going to the details of evaluation, but it generally includes a clinical evaluation, meaning that in the OPD, when you see the patient, along with the swallowing dysphagia team, we do a general clinical examination. We take the history and a clinical examination and do something called as a water swallow test. We give them a sip of water to drink and see if they are aspirating. It's not exactly a sip, but they say you can give up to 30 ml. But we don't usually follow that 30 ml principle. And then we check for any clinical signs of aspiration, whether it is safe to see, safe for the patient to swallow, and so on. So that is clinical evaluation. But the main part is the instrumental evaluation that includes a flexible endoscopic evaluation of swallowing, that is FEES, and a modified barium swallow or video fluoroscopy. So this is a picture showing our swallowing technician conducting modified barium swallow examination. This is the radiology fluoroscopy suite. And we get a lateral and AP view movie or a recording of the swallowing process when the patient is given barium of various consistencies. So that is a modified barium swallow or video fluoroscopy. And the next is a FEES. You all know about the endoscopic examination. And when this endoscopic examination is combined with the food, usually it is called as a FEES. We see the anatomy as well as the function and any abnormality of the pharyngeal stage. That is a flexible endoscopic evaluation of swallowing or FEES. So here you can see the Ryle's tube and the epiglottis and edematous AE fold and the food being given, and you first to look for anatomical problems, then any functional problems, and then finally you test with the different manures and identify the manures that can be given to the patient for a safe swallow. That is a flexible endoscopic evaluation of swallowing in short. So to compare video fluoroscopy and FEES, so video fluoroscopy involves a real-time X-ray, but FEES is just an endoscopic procedure. There is exposure of ionizing radiation in video fluoroscopy. The patient is either standing or seated in usually a radiologist suit in a video fluoroscopy, but in FEES, it can be even in the bedside or in the clinic. We get a lateral and AP view in video fluoroscopy, and in FEES, it is usually as similar to a scopy. It is a close-up view of the pharynx and the larynx. One disadvantage of FEES is that it can assess only the pharyngeal phase, but the video fluoroscopy can assess the oral, pharyngeal, and even the esophageal phase. Video fluoroscopy can detect the contrast material aspiration, but on the recorded video, but this has to be visualized. Even this can be recorded and for a future evaluation. Cost is generally expensive for a video fluoroscopy, less expensive for a FEES. Patient tolerance is almost the same. And but the equipment needed will be fluoroscopy machine and trained staff, especially the because of the ionizing radiation exposure. There is a lot of formalities to be completed for a fluoroscopy to be installed, but no such problems exist with a FEAST. And procedure length is typically shorter. It may take longer for a FEAST to give all the various consistencies and so on. So that is in short about the evaluation. Video fluoroscopy is usually considered the gold standard, but in any case, most of the cases we start with the FEES, and if required, we go on with the video fluoroscopy also. And most of the time it is complementary. Now we'll talk about the management part. So management of dysphagia problems in head and neck cancers or in any dysphagia comprises two parts, non-surgical and surgical. Surgical is usually referred to as a phagosurgery, similar to phonosurgery. When you do some surgery for improvement of the speech, it's called phonosurgery. And when we do some surgical procedures to improve the swallowing, we usually refer to those procedures as phagosurgery. And non-surgical techniques are compensatory techniques or rehabilitatory exercises. What are compensatory strategies? These are the strategies when there is no attempt to change the swallowing mechanisms. They are usually short-term or temporary adjustments that facilitate improved swallowing function without any lasting effects on the physiology of swallowing. So that is compensation. And it can be postural modifications. Okay, you give the food, or even with the secretions of the patients or saliva, you modify the posture, or you can modify the diet. The diet can be modified in two ways: either the volume or the texture, or even mode of presentation. And lastly, sensory enhancements. So the usual postural modifications are chin tuck, head turned to the weak sides, head tilt to a stronger side, side lying, head back, and so on. So all these are postural changes, and which may help in particular situations. Most of the time, it is a combination of many techniques or many posters that may be helping. We'll come to some of these while I go through the cases. So as I said, diet modification can be texture modifications or bolus volume modifications. What do you mean by sensory enhancements? We can do something called as therapy. You stimulate the pharynx with temperature, and this stimulation will help initiate the swallowing. And in that way, sensory enhancements may help. Carbonated beverages like soda or Sprite or something, temperature changes, then suck and swallow technique. And as I said before, method of presentation, whether it is with the help of a cup or a straw or a spoon and so on, depending on what the situation is. Now moving on to rehabilitatory exercises. These are the techniques which involve some changes in the physiology. We give them some exercises and depending on the plasticity of the muscles involved, there is a strengthening of the swallowing apparatus and swallowing muscles, and this will in turn help in improving the swallowing. So what are they? They can be divided into direct and indirect. Direct is when we give food and test, like strap muscle exercises, like Mendelssohn exercise, stretch exercises, airway protection exercises like supraglottic solo, supraglottic solo, pitch glides, base of tongue exercises like Masako maneuver, effortful swallow, gargle, and so on. I'm not going to the details of each of them, but each of one has a particular phase of swallowing that can be corrected or helped. But we may come across a few of them in the coming slides. And indirect exercises can be neck exercises, jaw exercises like range of motion exercises, lip exercises like labial range of motion. You ask the patient to open the mouth. Labial strengthening exercises, button and thread exercises, straw drinking. Tongue exercises like oral tongue range of motion, meaning that you ask the patient or the to put out the tongue and move the tongue in the extremes of mobility, upwards, downwards, laterally, and backwards, and so on. Those are range of motion exercises. And then strengthening exercises against some force. The patient is asked to move the tongue against some force, then it is called as strengthening exercises. Similarly, there are base of tongue range of motion and strengthening exercises, soft palate strengthening exercises, and laryngeal range of motion exercises. These are a list of indirect exercises. So with that, let us move on to some clinical situations where head and neck cancer treatment, where dysphagia is a problem, and how we could improve on them. So lip resections can be a primary closure or a flap closure. Okay, when you resect a part, may or may not involve the commissure. And finally, it can result in a microstomia and macrostomia. And added problem is the loss of sensation. I think there is a juggle of slides. So yeah, so this is a patient where we have resected the right angle of commissure and reconstructed with a flap. So here you can see there is a little bit of microstomia, as well as there can be a lip incompetence. So how do you correct it? So the component involved is the lip closure. So in dysphagia, there are different components and their impairment. There are 17 components actually, but the important ones are the lip closure, the lingual control, the mastication, tongue-based retraction, velopharyngeal closure, hyolaryngeal excursion, laryngeal closure, pharyngeal contraction, and pharyngoesophageal segment opening. These are the important components. Okay, so here the lip control is affected. So the impairment is the decreased labial strength, decreased labial range of motion, and it can result in micro or macro. The compensatory strategy that can be a macrostomia or weakness laterally. And of course, we can try a therapeutic texture or a bolus size modification. And coming to the rehabilitation, we can try a range of motion or button and thread or labial press exercises. So that is lip resection. Now moving to a case of a partial glossectomy. So this is a case of see a tongue, mainly on the dorsum of the tongue. You can see the tumor on the dorsum. And resection will involve the tumor resection with the margins and maybe a reconstruction. And that will mainly affect the lingual control. Okay, lingual control component. So here's a video of how this patient was resected, reconstructed, and she is using something called as a head back compensatory maneuver. So this is a post-operative day 2 or 3. Immediately, this was a not so large defect, the base of tongue, other swallowing mechanisms were affected. This was reconstructed with a radial forearm or a fan flap, but head back procedure. This is a compensatory maneuver that itself helped the patient to regain swallowing, and the Ryle's tube was removed. Now, here's a patient of total glossectomy and an ALT flap reconstruction. And the flap is, you can see the flap, the scopy video, the flap is reaching almost up to the epiglottis. You can see the fees video of the patient, and probably you could see the tubular epiglottis. Left piriform sinus is normal. That's a tubular epiglottis. There's some pooling in the postcricoid area and some secondary aspiration you can see. Sorry. So that's a fees. Sorry. And the video fluoroscopy, incoordinated oral phase, absent tongue-based retraction, oral residue. Okay. And penetration and aspiration. And the patient is being helped by a head back procedure. See, the patient is using or being instructed to do the head back when the penetration or aspiration is minimized. Some amount of penetration you can see. Penetration is the reaching of barium up to the glottic level. And when it goes beyond, it is called as aspiration. This again is the anteroposterior view. The food is going through the right side. The central part is where you can see the aspiration. And also the patient is using head tilt to the left. Okay. And then the aspiration was limited. So these are some compensatory maneuvers that could help in total glossectomy. So the impairment is in a total glossectomy is difficult with the bolus control, impaired bolus preparation. It's an oral phase problem. Impaired anteroposterior transport, impaired propulsion into the pharynx, and premature spillage into the pharynx. Compensatory strategy would be foot placement on the stronger side, head tilt to the stronger side, head back, and maybe slurp and swallow technique. And exercises like lingual range of motion, lingual strengthening, supraglottic swallow if there is a premature spill. Supraglottic swallow technique is mainly used for the glottic closure. So if there is some spillage into the larynx, all these exercises can be assisted with the supraglottic swallow technique. So that is glossectomy. Now coming to a case of buccal and mandibular resection. So here is a patient with a buccal mucosa cancer, resected with a marginal mandibulectomy and radial forearm flap. And here you can see he's trying to drink. There is, you can see the flap is a little bulky. It's an early post-operative period, and there is a pill. There is a lip control problem. And because the teeth and buccal mucosa is resected, there can be masticatory problem also. So what is a patient? So he is using something called as lip support. Okay. The patient himself is holding the lip or the commissure area and support it, as well as head back as a compensatory maneuver, and that helps him. So in buccal and mandibular resections, buccal resection, there may be reduced mouth opening or impaired chewing. Food can then be placed on the stronger side, and mouth extension and lateralization exercises may help. In mandibular resections, there will be loss of dentition, impaired bite force, reduced driving force of the tongue, reduced mouth opening. Food placement on the stronger side can help. Change in the consistency can help. And of course, lingual range of motion, lingual strengthening, lingual control, jaw range of motion, and Mendelssohn maneuver may help. There's a concept called a defective hyolaryngeal extension. So this is a forward and upward movement of the larynx when the patient swallows, and that is very important for the completion of the swallow, for the closure of the epiglottis, and finally the opening of the crico in the upper esophageal sphincter. So that part is called as hyolaryngeal excursion. In most of the oral cancer surgeries, like a symphysis mentae resection, floor of the mouth resections, glossectomies, tongue-based resection, this hyomandibular excursion can be affected, and that can affect swallowing in many ways. It can also happen in post-radiotherapy situations or partial laryngectomy situations. We'll come to that in a minute. So, for example, this is a case of a glossectomy with a mandibulectomy. So in surgically, it's important to anchor the hyoid to the mandible or a reconstructed fibula for the mandible so that it is placed little upwards. And that may help in the improvement of the swallowing. So that is a concept of hyolaryngeal excursion. Now here's a case of oropharynx. So robotic base tongue resection in the initial few post-op days, you can see pooling in the vallecula. But the laryngeal function is usually intact, the sensation as well as the movement, and the cuff reflex is important. So the patient usually improves very soon. 1 month postoperative, you can see the base tongue healing very well and swallowing very well. Usually we will be able to take out the Ryle's tube in a week or so in small base tongue resections without much intervention onto the larynx. But in open such procedures, if you're doing it as open, the morbidity or the swallowing problem will be more because of the involvement of the external muscles as well as the sensory supply problems. So robotic resections usually recover without much problem of this swallow. Here's another case of oropharynx, recurrent carcinoma glottis, post-radiotherapy, resection, and radial forum flap. So you can see the larynx, and this is a flap in the tonsillar fossa, radial forum flap. So here again, the sensation, the bulk, all these can create a problem. Let's see what's happening in the fees. There is edematous epiglottis, flap, as I said, it's occupying the lateral pharyngeal wall, and aspiration of the saliva. So that's a base tongue. That's a flap and the epiglottis. So you can see the secretions going into the glottis, maybe a penetration or an early aspiration. So in fees, we could see all this directly and may apply some compensatory maneuvers to compensate for this and correct it. So that is penetration you're seeing. 。          . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . 。 . . . . . . . . . . . . . And here is the video fluoroscopy picture. Here you can see an interesting finding soon, that if you could notice, there is a nasopharyngeal nasal regurgitation. Okay. So that is because of the velopharyngeal incompetency. We have resected the part of the see how the barium has gone into the nasal cavity. The lateral nasal wall and the soft palate may be partly resected, and so that is the reason for this nasopharyngeal uh, uh, velopharyngeal incompetency and nasal regurgitation. That's the AP view. And then some patient is being instructed to do some head tilt to the left. And nose pinch. Nose pinch is a procedure that can improve upon your velopharyngeal problem. And chin tuck. The patient approximates the chin onto the chest. So chin tuck plus, the nose pinch is helping the patient to get rid of that nasopharyngeal and velopharyngeal incompetency. So that was a case of recurrent CA tonsil post radiotherapy and resection and radial forearm flap. So what are the problems in oropharynx? If it is a soft palate resection, there is velopharyngeal insufficiency, there is loss of oropharyngeal pressure, leading to reduced bolus propulsion. Compensatory maneuvers like an obturator, nose pinch, or a chin tuck, or the food texture or bolus modifications can help. And therapeutic exercises like blowing against resistance, for example, like a conch, what we say, or a balloon. Blowing again into a balloon can strengthen your soft palate or velopharyngeal sphincter. If it's a tonsillar resection, it can result in premature spillage, and a chin tuck or head turn to the opposite side or head tilt to the opposite side can help. And the base of tongue resection, there is a loss of sensation because of the insensate flap, impaired bolus propulsion, and there is something called as tongue base retraction. There is widening of the retrolingual space, reduced laryngeal elevation, and then head tilt, head turn to the weaker side, chin tuck, multiple swallows, liquid wash, all those things can help. And base of tongue strengthening exercises like Masako. You ask the patient to put out the tongue with a gentle bite and ask the patient to swallow the saliva. So that is called as a Masako maneuver or an effortful swallow. All these will strengthen the base of tongue problems. So these are the impairment and maneuvers and exercises in oropharyngeal problems. Now coming to larynx and hypopharynx, we usually do a partial laryngectomy or a total laryngectomy. The partial laryngectomy common nowadays is a supracricoid laryngectomy, where we remove everything of the larynx, including the paraglottic space, and what is remaining is the hyoid bone and the cricoid cartilage. And in total laryngectomy, is in a way good for swallowing problem, because we are rechannelizing the trachea. Trachea is channelized out, so it's not coming in the way of the food. So that is good. But there are other problems in laryngectomy that can cause dysphagia. Because of the muscle, muscle resection, and the strength may not be adequate. And of course, late stages it can result in stricture. So there is no risk of aspiration except when there is a TEP leak or PC fistula. lower resting pressures in the PE segment, lower peak pressures after the swallow, discoordination between the contraction of the pharyngeal constrictors and relaxation of the PE segment. There is loss of normal negative pressure preceding the bolus and reduced pharyngeal clearing force. So these are the pathophysiological problems that is happening in a total laryngectomy. So here is a total laryngectomy solo, almost normal. But there can be problem when there is a pharyngeal muscles strengthening is affected. Now coming to supracricoid laryngectomy, it is a situation which requires a lot of help from the dysphagia management and dysphagia therapy. So this is a scopy video of scope picture of so after supracricoid laryngectomy. The epiglottis may be present, but there will be only some arytenoids, and this arytenoids epiglottis structure will be approximating onto the base of tongue to protect the airway. In the initial phases, there is going to be aspiration always. So here you can see massive aspirations in the early postoperative phase in one of the cases. But it requires multiple techniques, so compensatory as well as rehabilitatory techniques, and usually the patient improves within a few weeks. The supracricoid laryngectomy usually will have a temporary tracheostomy, which can usually be removed by day 6 or 7, and it will take a few more days or a few more weeks after the tracheostomy removal for the swallowing therapy to act and the patient to swallow better without a Ryle's tube. So that is a patient using a supraglottic swallow. Okay. Patient holds a hand and tightens his glottic aperture and swallow with a breath hold followed by a cough to get the residue, whatever which has gone out. So that is a supraglottic swallow. So what happens in the supracricoid laryngectomy? The physiological effect is the loss of volume of the pyriform fossa, no membranous cord, no A fold. There is delay in bolus propulsion, dysfunction in the elevation of the structures of the swallowing. There is reduced airway protection, reduced pharyngeal clearance. There is pooling in the neopyriform sinus, edematous arytenoids, secondary aspiration can happen. And strategies like supraglottic swallow, supraglottic swallow, chin down, head rotation, head tilt, and consistency modifications can help. And therapeutic maneuvers like in addition to supraglottic and supraglottic swallow, effortful swallow and tongue-based retraction exercises also may help. Here is another problem usually that can happen after laryngectomy is a stricture. So we'll come to that. So there's a problem with the pharyngeal contraction as well as the PE segment opening. The PE segment problems can be structural when there is a stricture, or sometimes it can be also due to a spasm when it is usually a neurological sort of problem. Spasms can be corrected by the help of the botulinum toxin injection, which relaxes the cricopharyngeal sphincter. And if it is a stricture, it may require dilatation. I will come to that. So we can identify it in barium swallow or fees. In the initial phases, it may be just mucositis when supportive care can help. But then later may require serial dilatations. And if there is a complete stricture, then which is not amenable to dilation, we may have to do some surgical correction. Now, head and neck problems or head and neck surgery is also sometimes associated with the cranial nerve palsies. The 7th nerve, 9th nerve, 10th nerve, 12th nerve can cause problems. And procedures like thyroidectomy, parotidectomy, skull-base surgeries, neck schwannomas, paragangliomas excision, all those things can produce cranial nerve involvement and palsies. So here is a complicated case of a skull base resection, and this lady, sorry. Right-sided cranial nerve palsy post-skull base surgery with vocal cord immobility, phonator gap. You can see the pooling. Lip closure problem was there. There is pooling in the right piriform sinus, right vocal cord palsy. You see the Ryle's tube. And the palatal palsy, you can see. The tongue palsy, you can see. So it's a multiple problems usually when there is cranial nerve involvements. And it's being helped by compensatory maneuvers like straw drinking. There is a facial nerve palsy, so there is loss of strength of the commissure area. The patient is using a straw to drink. That's one technique. And here, for the lip strengthening, a rehabilitatory technique called button and thread exercises is being employed. There's a button and a thread, and that is held in between the teeth and the lip. And the patient is trying to hold it in between the lips, and the person outside is trying to gently pull it out, and that will strengthen the lips. So that is a rehabilitatory technique for lip strengthening. So such techniques may help in this patient. So that's about the surgical dysphagia and management. Now let's talk a little bit about radiation related. So there is a lot of role for prevention in radiation-related dysphagia. Surgery, it may not be not that much because we have to resect it and then we have to rehabilitate it. But there is a lot of role for prevention in radiation-related dysphagia. And how can this radiation-related dysphagia be prevented? First and foremost is in the hands of the radiation oncologists. They can plan it. They can plan the radiation and they can protect what is called as DARS or dysphagia aspiration related structures. That is the swallowing related structures like the constrictor muscles, the supraglottis and so on. If they can contour it and avoid those areas in the field of radiation, they can prevent those muscles being affected, those areas getting mucositis and so on. So that can prevent the radiation related dysphagia to some extent. And while the patient is on radiation, the patient has to be encouraged to be on oral diet. There may be pain. The pain has to be managed very well, and the patient has to be continued on oral diet if it is safe. Of course, we need to see the safety, whether the patient is aspirating or not. And there is also a role of prophylactic swallowing exercises. So there's a concept of prehabilitation and prophylactic swallowing exercises. So there is systematic reviews and randomized control trials now favoring this prehabilitation and prophylactic swallowing exercises in radiation. So what is prehabilitation? They are proactive measures to optimize swallowing function before cancer treatment begins. And those aims to minimize the impact of treatment-related side effects on the swallowing function and to improve the overall quality of life. What are the components of rehabilitation? Pre-treatment assessment, patient education, swallowing exercises, nutritional support, psychosocial support, and collaborative care. All these will improve. The patient will be primed to undergo the radiation, and because of which the swallowing outcomes is supposed to be better with prehabilitation. So what are the prophylactic swallowing exercises? So while the patient undergoes, or prior, maybe 1 or 2 weeks prior, they are initiated on prophylactic swallowing exercises. These are a set or battery of exercises which acts upon different phases of swallowing, like same exercises like a full swallow, supraglottic swallow, tongue hold maneuver, tongue retraction, Mendelssohn maneuver, and the patients are instructed to perform each of these exercises 10 times, 3 times daily, and vary the order of exercises. So this is how we usually employ prophylactic swallowing exercises in patients who undergo radiotherapy. So these are the steps we have to take while the patient is undergoing radio. The pre-treatment, these are the things which needs to be evaluated. Disease needs to be evaluated. Dysphagia needs to be evaluated. Nutritional status needs to be evaluated. Dietary advice to be given. We have to take a decision on the feeding tube support, dental evaluation, pain management evaluation, and again, this prophylactic swallowing exercises. This is pre-treatment. While during treatment, again, conformal radiotherapy, swallowing, feeding tube support, oral hygiene maintenance is important. Mucositis prevention is important. Pain management while during radiotherapy is important. And prophylactic swallowing exercises has to be continued. After treatment, again, swallowing evaluation is important. Pain team management is important. The swallowing exercises has to be continued, and dental evaluation and fluoride gel application also has to be continued lifelong. So this is how the patient undergoing radiation, for example, for an oropharynx or larynx or hypopharynx, has to be helped with to improve the outcomes in swallowing. But sometimes there can be late dysphagia and strictures. 50% of the patients have chronic dysphagia associated with chemoradiotherapy, and 37% progress to symptomatic stricture. 7 to 30% progress to develop a complete stricture. What is the pathophysiology of stricture? It can be a mucosal injury or mucositis initially with mucosal edema involving the superficial mucosa. There will be acute dysphagia, which may resolve spontaneously. Then in the intermediate phase, there may be deep submucosal or muscles may be involved, and finally it can result to this. It may result in this complete stricture. The risk factors can be radiation-related factors like the dose, fractionation, target, or technique, and non-radiation-related factors like chemotherapeutic agents, tumor, stage, site, age, sex, comorbidity, and general health status of the patient. So here's a patient of carcinoma hypopharynx post-chemoradiotherapy, 2 months. And you can see the mucositis persisting, mucosal edema, and stasis in fees. And the VFS showing trap penetration and aspiration. So let's see. So these are the mucositis, persisting mucositis, edema, the secretions, penetration, aspiration. It's just 2 months post-treatment. Edema. And here you can see the penetration of the barium. And aspiration, okay? You can see that tracheal lining with lined with the barium. So there is frank aspiration. Patient is on tracheostomy. So patient has to be given adequate analgesia, anti-edema measures. The patient is not fit for tracheostomy decannulation or feeding tube removal. The patient has to undergo intensive swallowing therapy to get rid of the tracheostomy and the feeding tube. So that's a case of carcinoma hypopharynx. Now, another case of carcinoma larynx post-chemoradiotherapy with a late onset dysphagia. Let's see what's happening in the fees. There is pooling in the piriform sinus. Laryngeal elevation, hyolaryngeal elevation is affected. There is something in the fees called as the whiteout phase. Usually when the patient swallow, the larynx comes and hit the scopes, and there is a brief phase of whitening. And that's not happening here, if you can see. We are just progressing to see the larynx, but the larynx is not coming up. So there is absent hyolaryngeal elevation, and it's almost a plastered larynx. There's not much moving. The left hemilarynx is fixed. There is some amount of penetration. There is pooling in the left piriform sinus. That's the late onset dysphagia and stricture. Okay, and in VFS, there is a hyolaryngeal excursion is incompetent. Stasis, you can see, penetration and aspiration. Okay. So this is a hyoid bone. It's not much moving anteriorly. That's absent hyolaryngeal elevation. And there is stasis. It's not moving down. There is stasis in the vallecula, stasis in the pyriform sinus, and penetration. Okay, you can see the penetration. So again, this patient is also not fit for oral trials. Patient was on PEG tube. Neck strengthening exercises like shaker exercises, neck muscle strengthening, neuromuscular stimulation sometimes can help and may require ciliary dilatation. And if this patient is not improving, we may have to consider a flap pharyngoplasty. Here you can see the penetration happening. This is with the thick barium. This pooling. The epiglottis is not closing. You can see the epiglottis here. So that's a case of carcinoma larynx post chemoradiotherapy with late onset dysphagia. It's a post laryngectomy stricture. I think we talked about it. And again, this also we can do. If there is a note improvement with dilatations, we may have to do a surgical correction. Serial dilatation can be done with balloon or bougie dilatation. Short-term steroids may help reduce inflammation and scarring. PEG tube, if required for nutritional supplementation. Oral diet has to be encouraged if it is safe, and multidisciplinary care, including swallowing therapy. This is a video showing esophageal dilatation. Previously, we used to do it in our OPD itself with dilators, but nowadays gastromedical specialty is very well equipped with all the instruments and scopes. So they usually do it for us. And repeated dilatations has to be done, maybe once in every 3-4 weeks. And the situation may improve for a few months, but then later, if it is not improvement, it can go to a phase where there is not improvement, and then we may have to do a surgery. Pharyngoplasty surgery depends on the location of the stricture, length of the stricture, functioning larynx, whether it is within or outside the field. Reconstruction it is to restore the functional patent lumen. A stricture segment can be augmented, bypassed, or excised with a range of reconstructive techniques like regional flaps, like DP flaps, pectoralis major, gastric pull-up, colonic interposition, or free tissue transfer like radial forearm, anterolateral thigh flap, or jejunum. I'm not going to the details of it. So to summarize my talks, the disease, the surgery, and associated radiotherapy can lead to significant swallowing dysfunction in head and neck cancer patients. It's important to recognize the swallowing impairment in each clinical situation. And management is most often with compensatory strategies and rehabilitatory exercises. Phagosurgery, the surgical management is required in certain situations, and they need to be promptly identified for better outcomes. Before I end, let me bring into the notice of the audience about this book which we have written, Dysphagia Management in Head and Neck Cancers. Whatever I have talked today or told today is there given comprehensively in this particular book of Dysphagia Management of Head and Neck Cancers. Thank you.
So, sir, thank you so much. Wonderful class, case-based discussions on dysphagia diagnosis and management. I think, sir, there are a couple of questions in the chat box. Yeah. So how does the head tilt and turn differ for tonsil resection, BOT resection, and high vagal palsy? I think, sir, for different sites or resections, they are asking.
No. Different sides it may be, but the head tilt and is mainly gravity dependent. Okay, head tilt and side tilt, and there is head turn also. So head tilt is mainly gravity dependent, and you turn the head to the uninvolved side. For example, in a laryngeal palsy or a pharyngeal palsy, head tilt is the head can be tilt, or the patient itself can be side lying, so that the gravity will help in the movement of the foot downwards. In head turn is usually to the the stronger side. So that usually a combination of these techniques will help in the improvement. It may not be
Right.
different for different things.
Right, sir. Sir, can you please give your opinion on prophylactic feeding tube placement before adjuvant radiotherapy in cases of extensive surgery? I think they are asking for prophylactic. What's his reactive? Or, sir, this is the question. Can you give your opinion on prophylactic feeding tube placement?
Yeah,
Before
generally so there is something called as a prophylactic and reactive. Reactive means when the patient develops problems, you put the Ryle's tube. And prophylactic means we give it before. Generally, the thought process now is that the prophylactic may not be very good. The patient, we have to watch for any symptoms or problems, and the more better will be to put it in a reactive way, because there is something called as disuse atrophy. So if you put it earlier itself, there can be the patient may not use the swallowing muscles properly. That is one thing. Then the Ryle's tube itself can cause problems in the swallowing, like it can cause edema, ulceration, and all those things. So generally, we prefer or we favor a reactive rather than prophylactic Ryle's tube insertion, feeding tube insertion. Yeah.
correct. Sir, another question. How early we should start prehabilitation in surgical patients before extensive surgical resection of oral cavity cancers?
Yeah. So as I said before, prehabilitation is also important for surgical patients, but not that important as we see in a patient going for radiation or chemoradiation. It is always good to involve the swallowing dysphagia therapy team in the first visit itself. The patient may be asked to visit them. So they will be explaining them on how the course of the treatment is going to be, and they can give some psychosocial support and explain the therapy techniques, which when the patient is fully conscious or fully oriented and all those things. And those advices and therapy demonstrations may help in a later phase. So in oral cavity, there may be some amount of dysphagia because of the tumor itself, and there may be a lot of pain. So exercises may not be practical before the treatment, but again, see the patient being seen by the team, explaining them the situation and giving them support will always help. Prehabilitation is more important for patients undergoing radiation treatment than for oral cavity patients.
Right, sir. Sir, this is one question. Can you elaborate on laryngeal ROM exercises?
Laryngeal aroma exercises is like a pitch glide and so on. Like they raise the voice. I mean, the voice has to be is asked to they are asked to produce the voice to increase the pitch and the duration and so on. So that is how laryngeal range of motion. Range of motion exercises is to get their maximum range, even if it is a larynx or lip or tongue or whatever it is. Mainly, it is like a pitch glide sort of exercises.
Yes, sir.
Yeah.
So, sir, with this, we can conclude our lecture today. Sir, thank you so much. It was a great lecture, and
Thank
we
you.
all learned a lot. Thank you so much, sir.
Thank you very much. Thank you.